which is about 30 years from now.
Having healthcare today, in different areas based on the offices he has occupied, both in the quality aspect of healthcare and also in reproductive health. So we have with us today Dr. Richardson Ajayi, the founder, the Bridge Clinic. He's also a member of the steering committee of the Health Policy Commission of the NESG. So you're welcome. With us also this afternoon to give us the keynote address is also someone passionate about the healthcare industry who has invested money, time, and everything it takes to move the healthcare space, especially the private healthcare space in Nigeria, to where we have it today and still advancing that cause. So make welcome with me, Madam Fola Laoye, Mrs. Fola Laoye. She's the co-founder and CEO of Iwosan Investments Limited. Madam, you're welcome. Thank you for coming. So with that, I also have, forgive me, before she will sack me from her policy commission, my own very Oga at the top, she's the facilitator of the Health Policy Commission at the NESG, Dr. Morris Atoki. You're welcome. So with that, I'm going to go on to the next item on the agenda, which is the welcome address by Dr. Morris. And then we are also going to have the opening remarks, followed by the keynote address before the panel session. So in that order, we're going to proceed, but we have to do some housekeeping just in case somebody might want to use the restroom, you want to use the convenience. We have two, one on this side and one on the other side. Once you open this door, there's, there are two different entrances to which you can access, through which you can access the restroom. All right. So Dr. Morris Atoki, the facilitator of the Health Policy Commission, will welcome our audience. Thank you.
Thank you so much, and good afternoon, everyone. See, when an Oga at the top says that one Oga at the top is going to sack him or her, you know that um, he's only speaking on the contrary. Dr. Benson, I really must appreciate you to start with for this remarkable topic and gathering that you and your team have helped us put together at the Nigerian Economic Summit through Health Policy Commission. Indeed, it's high time that we take this conversation a bit more seriously in advancing health and healthcare. My part is easy, you know, I'm not a techie like most of them here. Is to give you the welcome address, to give you a bit more understanding about who we are in the Health Policy Commission, why we do what we do, and the strength behind what we do. Again, my name is Maurice Zatoki. I'm the facilitator for the Health Policy Commission of the Nigerian Economic Summit Group, and I double as the Chief Executive Officer of the African Business Coalition for Health, a not-for-profit founded by Alhaji Aliko Dangote and Mr. Aigboje Imokwede. The conversation today and topic, Catalytic Capital for Healthcare, Bridging Nigeria's Systemic Gaps, to be held on the back of the coming summit. So today it's a pre-summit on today, the 14th of August, 2025. Couldn't be more urgent or strategically timed. Under the overarching summit theme, the reform imperative, building a prosperous and inclusive Nigeria by year 2030. Our deliberations today center on a sector that is both the foundation and the engine of sustainable prosperity, healthcare. Inadequate health systems not only erode human capital, but also undermine economic productivity, resilience, and social cohesion. Nigeria's healthcare ecosystem stands today at a critical inflection point. I'm sure you've heard these words before. We cannot overemphasize it, but we need to remind ourselves. It's appalling where we are. That's the generality of the situation. Yes, you and I can afford to go to some hospitals that, you know, and get healthcare that serves our needs in Nigeria and beyond the shores of the country. But let's also remember that over 90% dare not, and largely because they cannot afford to, largely because they cannot afford to. Data tells us compelling stories that the private sector currently serves over 60% of the population health, yet remains undercapitalized and highly fragmented. Public sector facilities are constrained by inadequate funding, infrastructure, decay, and ongoing challenges of medical care, brain drain, diagnostics, an indispensable pillar for early detection. Cost-effective interventions and improved outcomes remain significantly underfunded. Affordable quality diagnostics alone could dramatically reduce late presentations and improve survival rates. Yet, the market remains nascent. The focus of today's congregation and conversation is therefore to deliberate on exploring catalytic capital, strategic, risk-tolerant financing designed to de-risk early-stage investments, crowding private capital, and unlock systemic change. By aligning development finance institutions, commercial banks, private operators, and governments, we can mobilize funding into underserved but high-impact segments of the healthcare value chain. From primary care, infrastructure, and local manufacturing to digital health platforms, to supply chain resilience and innovative health financing models. Our shared vision must go beyond funding healthcare in isolation. We are here to finance resilience, to move from fragmented investments to systems thinking, ensuring that every capital injection strengthens Nigerians' capacity to truly deliver quality, accessible, and affordable healthcare on a sustainable basis. And this requires policy reform. It requires innovative financing structures. It requires kind of conversations that we're going to have here. It also requires regulatory clarity and genuine private-public partnerships. I extend my deepest appreciation to all of us here today, particularly the very, very carefully selected panelists. Your presence signals not only commitment, but also influence, the kind of influence that can shape the trajectory of Nigeria's healthcare investment landscape. The discussion we have in this room can lead to practical investment frameworks. I have people like Dr. Benson to rely on for that. They're passionate, and there are other leaders of thematic groups. All they do is think about health in Nigeria, and they can take us to where we want to go. As we look forward to the 31st Nigerian Economic Summit, let today serve as a catalytic moment in itself, a platform where expertise, capital, and political nuances will converge to bridge Nigerian systemic healthcare gaps. Let today be one of many deliberate touch points where we build the resilient, self-reliant, and inclusive health systems that Nigeria urgently requires. On behalf of the Nigerian Economic Summit Group, on behalf of the Health Policy Commission, I welcome you all and warmly wish you a productive and result-oriented deliberation.
All right, thank you, Dr. Morris. With that, I'm going to be calling on Dr. Richardson Ajayi to give us opening remarks. You're welcome, sir.
Good afternoon, ladies and gentlemen, and thank you very much, my Oga, our facilitator, Dr. Atoki, and my other Oga, Dr. Benson Cole, who is the thematic lead. I'm a member of his group, so thank you for this opportunity. And when I came in, I had cracked a joke with you. I said, another conversation on healthcare financing. I've been going to these for 20 years. But you know, ladies and gentlemen, it's a conversation that we can never stop because of the pivotal importance of healthcare in national development. And we haven't gotten it right. We know the challenges in the public sector in terms of underfunding, dilapidated infrastructure, brain drain. Private sector is rising to fill the gap, and indeed more than 60% of healthcare needs are met by the private sector. But the private sector also has its own problems in terms of investability. So what is the solution and how do we move forward? Permit me to share my own personal experiences. As far back as early 2000, at the Bridge Clinic, we realized we needed a good laboratory. And the point wasn't let's just build and buy, let's get an operating partner. So we approached Pathcare, a company in South Africa. South Africa has three big players, Pathcare, Lancet, and Ampath. So we got one of them, come and join us. And they looked at Nigeria, looked at the population. The population in South Africa is about 50, 60 million, Nigeria 200 million. And they said, wow, let's go. And they came and said, the strategy is we will build the first ISO accredited laboratory, 15189. What does this mean? It means if you get a result from our laboratory and take it anywhere in the world, it's accurate. And we're going to use this thing to really transform West Africa. They were really gung-ho. So they came and we started and we grew, but not to the pace that it satisfied their own financial appetite. And why was this? Because yes, we had the 15189, but nobody cared. Okay, nobody cared. So you were just another lab that was a little bit more expensive than others. 15 years after the effort, they called us one day and said, this thing is not working. And they decided to divest and leave Nigeria. Similarly, another story. So why did they leave? They left because, yes, they had the financial muscle to continue to grow, but our landscape was not enabled for that growth. Similarly, I think Njide is here, I think she was part of it, the Red Book, late 1990s, early 2000, the case for investing in private healthcare in Africa, because the financiers saw that there was this opportunity because private sector was doing a lot of the work, but let us accelerate growth. And so the Africa Health Fund, Bill and Melinda Gates North Fund was born. $100 million to start up with. I think they grew it about $1 billion eventually to focus on how healthcare, and investments were made. And we were one of the beneficiaries. And we were working very hard. We built a state-of-the-art laboratory. ISO this, ISO that. Nobody cared. So the point I'm making, ladies and gentlemen, is that the issue is not the lack of funding, because money is desperate for opportunity. Money wants space to be invested in. But what are we inviting them to invest in? And I think that, to me, is the question we need to answer. Let's look at the landscape of healthcare. Private healthcare is highly fragmented, led by solopreneurs who are sole doctors doing their own thing. You can't invest in that. So what is the private sector? Let's look at the power of buyers, okay? Looking at the demand side. Health insurance penetration is low, so people are making 70 to 80% of purchases out of pocket. They can't afford healthcare. So let's look at the supplier side of things. We're not manufacturing a lot in Nigeria. We're importing everything. With the Forex challenges we have, it's too expensive. So this is our landscape. And how do we change this? So I got very excited last year when Dr. Tunji Alausa, the then Minister of State for Health, set up a committee, Nigeria Health Facility Regulation Agency. The core, you're part of it. Njide, you're part of it. And the idea is, let us look at the healthcare landscape and put a regulatory framework around it. Now, they're looking at patient safety, which is important. But I believe it goes together with investability. And how do we create these structures? So first, what is a hospital? Today, anybody can call anything a hospital, because the Nigerian Health Act 2014 asks that every provider must have a certificate of standards. So we define standards for investability as well as safety. We haven't done that. So let me not take too much of our time, because mine is opening remarks. I believe the conversation today, really, we need to talk about catalytic finance, blended finance, and how do we de-risk. But more importantly, how do we make the space investable? Because I really believe money is looking for opportunity. I mean, we have Sterling Bank here. We had a conversation earlier on. And the issue is not, and thank you, they invested in Pathcare when we started. They are one of our private equity investors, and they helped us because we could see the numbers. And I think, how do we create those structures that make healthcare investable? That is what I would like to hear in our conversation today. So thank you very much for this opportunity. Mrs. Laoye, thank you.
Thank you, Dr. Ajayi. We won't get discouraged now. Having heard that. Yeah, I always believe that we have, as stakeholders, we have a part to play And of course, the financiers have their parts to play. And that's why we're here to catalyze the space, by bringing actionable solutions. So it's not another talk show. We want to be able to leave the room and then get some things actually happening in the space as offshoot of the conversations we're going to have today. This is a pre-summit event, like you've heard, get towards the 31st Nigerian Economic Summit coming up in October. So the conversation continues even after now, and I believe that we're certainly going to get it right. So thank you for your comments, and thank you for making yourself available to share your story, your journey. I'm sure that as we continue to say these things, we'll continue to learn, from the journeys we have all made individually and then collectively. So with that, I'm going to welcome Mrs. Folala Oye, the co-founder and CEO of Iwosa Investments, to give us the keynote address. Thank you.
Good afternoon. I hope you can hear me. Yes, okay. I know I had a few slides, but I don't know if they'll come up. Okay, great. Okay, well, it's actually nice being in this cozy room because I feel I've everywhere I turn, the faces are all faces that are well known to me and well known to each other. And that's great because it really can be a conversation, It's a conversation, as Dr. Richard has said, we've had many times before. So what makes this count? What makes this count for me is NESG. NESG, and I don't know those who know the history, I'm not here to give the history, but I'll tell you one very specific item of information that I don't know how much you know, but it was in a session like this, in conversations like this, that the whole concept of the national health insurance was really, really baked and executed. So it was with people before us, who were in the room, who sat and said, it must be done. And they got the backing of the various stakeholders that NESG had convened and were able to take it to the head of state at the time. They stayed on it for 5 years until the law was executed. So the convening power of NESG is my point. We mustn't take it lightly. It's a conversation, but it's not just another conversation, because when we're here with the convening power of NESG, really being able to put the public and the private sectors together and to really have it done in a meaningful way, I believe we can really start to see, ways in which we can implement, whatever story we're discussing. And the story being the really key one of how do we catalyze the healthcare space in Nigeria. So I guess I have to do next slides, please, right? Okay. Okay, next slide, please. To be honest, some of my slides here will be information you are so familiar with. So I'll run through because I don't really want to take your time. But we know the issues. We know the population. We know how much we're spending. We know how much we're not spending. We know what that has done in terms of, life expectancy and really what that has happened to the healthcare workforce, because that really is the crux of it. So we're not spending enough, not nearly enough. We're certainly seeing a higher level of disease prevalence than we've ever seen before. We're seeing the shift of spend and of care to the private sector, and we're seeing the japa of our healthcare colleagues. Next slide, please. But at the same time, what makes some of us still think about this? we think about it from the private sector's perspective, and we can think about it as the private sector. Now, if you have to think about it from the public sector's perspective, it's a totally different story. But here we think about it as a market, and a market that actually, when you add it all together, is about a 40 trillion naira market today. And most of that market certainly is in the supply side. 15 trillion is hospitals, clinics, where people go and get care. Now, there's another 10 trillion above that is also, like we've said, Dr. Richard mentioned, laboratories, the diagnostics, it's the pharmaceuticals, all the inputs, shall I say, of care. And then, of course, there's the fledgling amount that is what I'll call the demand side. Really being able to make sure that what people are spending out of pocket gets better, constructed through the insurance schemes. But all told, it's a 40 trillion naira market, which is, whichever exchange rate you use, somewhere between 15 and $20 billion. So today, that is today. And of course, it keeps growing. Right now, it is, we are seeing now the fact that it is likely to grow about 7-8% a year. And so you can keep doing those numbers. And that's really just because people will consume. We are a population, and that population will consume healthcare. And that population will find some way to pay for it at the end of the day. They will search for it. Of course, a large part, well, not a large, a very small part of the population accounts for a very big spend. And a lot of that spend, they are spending even outside our country, right? All the medical tourism. And again, those are conversations you are all very, very intimately aware of. So whichever way we cut it, the point is, indeed, there is a market to serve. And so we try to think about it like that. And it helps because when you talk to the folks in the NESG, these are economists, right? They are business people. And it was the same way when the health insurance conversation started. It was made an economic issue. And that was when the stakeholders came together to say, how do we solve it? It was made an issue for employers of labor. What are you spending? Where's the quality of the care? What's happening to your staff, your employees, and what does that mean in the end to your businesses? And once that economic argument was properly constructed, everybody moved. So we need to think about that again. So next slide, please. Okay, so again, I think next we can even skip this one because it's the same story. So I'll go now to defining catalytic capital, because that's what I believe, those in the summit have already identified, that if we can do something game-changing. I mean, and again, I like to think about health insurance when it happened as being game-changing. This was 1998, 1999 that this conversation was happening. And at that time, it was game-changing. It ended up starting a health insurance scheme where 4 million people were put into the pot almost from day one. And that was game-changing then. Unfortunately, it hasn't picked up as quickly as we had all hoped. We had hoped by 2015, we had hoped that in 10 years, we were going to get to 30 million lives. Now it's been 20 years, 2025, and we're still not even at 20 million lives. So it hasn't quite worked, at least as fast as we thought. But I'm just saying that at least there was a sort of a gauntlet was thrown and it started. And that's what we mean when we say catalytic, something that is so significant that, it certainly makes a difference. In the case of healthcare, I think there are a couple of key issues when we talk about capital funding, and that it has to be patient. So again, I liked what Dr. Richard described as his story. It's a story quite a few of us in this room have lived. I lived it too, running Hygeia and Lagoon and so on. The Red Book, we all sat together to write different, versions or, paragraphs, because we knew we needed the world to hear our story. And it was very instructive, because what happened then, as Dr. Richard said, was that we attracted foreign capital both as operators, like the Pathcares, and as private equity with different funds, as again you mentioned. And that was interesting. But there was something that was still missing. It was foreign. And that meant a couple of things. First of all, the return had to be in US dollars. And straight away, like you said, we did not have an economy that could sustain that. We had an economy that was devaluing the currency every year. And so for investors who are sitting outside, that just did not work. And so what was the result of that? They were not patient. They couldn't afford to be patient. And not because they didn't like us or like the market or feel they were making an impact, but it was a hard cash issue and a return had to be made. And in that kind of setting, they couldn't afford to stay too long if, they could see that their investment would continue to devalue. And so was their capital patient? It wasn't. Most of them, I was even glad to hear Pathcare stayed 15 years. Most of the investors then stayed 5, if we were lucky 7, because, they had to get out. And I think that was a fundamental issue about that type of capital. Then, of course, risk tolerant. No, nobody wanted to take Nigeria risk. So the cost of the capital was very high. The interest rates and so on were very high. So again, especially when you put that with the currency and the interest rates, it was very difficult. But was it impact driven? Yes, it was. Does it still need to be impact driven? Definitely it does, because we still have to do what I will call, the double sort of return, the double layer of return, being we want to make sure that we're looking after more people and getting people healthier, but we also need to make a financial return. So it's a double bottom line. Next slide, please. And so just talking about that again, these are all things The infrastructure gap is huge, whether it is on the public side, whether it's on the private side, the infrastructure gap, and it's getting bigger with the kind of diseases we're having to look after, and also where the world is heading in terms of looking after those diseases. In most parts of the developed world now, cancer has become almost a chronic disease. It's not the death sentence it used to be. Now people live with it, just like they live with heart disease, just like they live with diabetes. So, but here, those things are killing us now every day. Because first of all, we can't even identify it. We can't diagnose it properly. When we diagnose it, we can't treat it fast enough, and so on and so forth. We can't afford it, or even when we can, it's not available. So we're in a very difficult, so if you bring that infrastructure gap with the burden of disease, it's a double whammy. And then the demand, the population is rising and rising and rising. We're 150 million today, we're suddenly 200 million. We're now saying we're 240 million. The numbers are staggering, but it's happening. So how do we, when we see what numbers we're meant to be in 2050, we're meant to be 450 or 500 million people. How are we really going to get this, these people looked after? How are we going to get our people looked after? And so certainly unlocking the access to capital in a sustainable way is really, really what the catalytic part of capital needs to be. Next slide, please. Need to go. Oh, you can't hear me. I'm sorry. I'm not. Oh, I'm so sorry. I never work well with mics. Sorry. Okay. Sorry, I think I'm better now. Okay. So next slide, please. So interestingly, President Olusegun Obasanjo, who, was president a couple of times, I won't say many times, but a long time ago, but he's still, even in his 80s, talking about this stuff. And it's very important to hear him for me because, again, he was the catalytic, shall I say, political force that really got health insurance going and threw down that gauntlet in the end. And so for him now, just last week at the Africa, I think it was the health, thank you, sovereign for, there are so many conversations. I can never remember the names anymore, but in Accra, spoke to this issue. He said, we have to create an African health fund. Because guess what? We can't rely on the donor world anymore. That's been pulled. The rug was pulled out under us so quickly. We're still not even really sure how we're going to handle that. And we know the level of the level of deaths that are occurring just because of this funding having just left the system. So we can't rely on that. Just as I said, even us in the private sector had realized that, foreign investment was only going to be very nascent. Similarly now, we've got to go from aid to autonomy, he says. And we've got to hardwire investment through insurance. He says 25% of health insurance funds should also really go into infrastructure to ensure that we're building stable and sustainable capital. That in a way happens because what insurance does, what is insurance? Insurance is the demand side, right? And if you're thinking again, as I do, we're in a market, then certainly those who buy are the ones who at the end are going to build the market. Everything will be built around them. So the more you get people in, the more they buy, certainly the more the services can be provided and afforded. So yes, indeed, that's key. So we've said, yes, we need to make sure that we are de-risking our models of financing. We need to act as a magnet for unlocking larger pools of funding. And when it is mission-driven, when mission-driven investors bring that capital first, it signifies confidence. In a way, it's like Nigeria over the last, shall I say, 6 or 7 months. There's been a lot more confidence, right, in the country and in the way investors are looking at the country. And that in itself is bringing more to the table. And so healthcare is not to be left out. Let me put it that way. We've got to make sure we're not left out. Next slide, please. So I'll just very briefly tell you what we are doing at Iwosan. Again, telling our story. A lot of words, but basically Iwosan, we set up about 5 years ago to be a proudly Nigerian company, to be a company that was now going to raise capital locally, as opposed to raising capital from foreign clients. We want that capital to be long-term, to be patient, and certainly to really go through the motions of funding hospitals, clinics, funding largely the supply side, because we believe that infrastructure breakdown needs significant long-term local capital to come at it. Same thing with training, because again, government and what is going on now with JACPA and so on in the teaching and system in government certainly needs private sector now to work hand in hand. So we've seen that, we've read the memo, we are convinced that that is where we should be. And that's exactly what we're doing. Next slide. What have we done? So since we got started, well, we got started in 2019, but then COVID happened. So we had to sort of pause. But by 2021, we were active. We acquired Lagoon Hospitals, and then we expanded Lagoon and expanded. And then we started in the last year working now on other projects, the Lagos Medipark project, which I'll talk a little about. And then we also acquired Uracare Specialist Hospital. Because in our model as well, something else we've identified is, yes, we are going to need to do shall I say, a combination of new builds, but also collaborations and acquisitions. Because again, healthcare is an area where we don't have a succession plan. most of our entities don't have a succession plan. And in a way, even on the government side too, there's a little bit of that, which is why we're finding that a lot of government hospitals, are now emptying, especially regarding their specialists and so on, but particularly on the private side. Most private entities, as you know, have been very small, quite fragmented, what you call the typical mom and pop. And when the mom and pop get to a certain age, children are in Canada or US, that's even if they did medicine, maybe they did, maybe they didn't. What happens? Now, I see myself as a succession plan. So my story, my personal story, is that my parents worked in Luth for many years. They started Luth in the 60s and 70s. And then in the 90s, went into shall I say, private, and built Lagoon Hospitals and built Hygeia, the HMO business. And I joined them at some point in that trajectory. And that's why I'm still here. So I'm that succession plan. But there are not many like us. We see a few more, and I'm glad to see more. I'm always so encouraged to see more people who, see the next generation. But my point is that succession plan as an industry is something that we realize there is a lack of, and there's something we can do about it. Next slide, please. Almost done. So with that story, with our story, and with what we're doing already in bringing capital together and doing these projects, we've identified some key things that we think can be catalytic. One is a real supply side focused healthcare infrastructure fund. And it's important I say this because I don't know how much you know, but infrastructure funds, not healthcare, but infrastructure funds have now become the new thing, the new kid on the block here in Nigeria. Almost all the big banks have them now. Stanbic has a big one, UBA, you call them. Everybody now has their own infrastructure fund. The reason being because they are a fund that pension money can go into. And pension funds right now are more trillions than I can count, literally. That's how much we have saved, again, since President Obasanjo's time, when the PENCOM Act was enacted and money was put together. And so now these funds need somewhere to go, because all they've been doing is buying treasury bills and funding Nigeria's debt. But now everybody's woken up to the fact that they can be used to build infrastructure in country. So there are quite a few infrastructure funds now who are building a lot of the discos. What you're seeing now in power are funded now mostly by PFAs or through infrastructure funds, because PFAs cannot fund directly. They must go through these funds. So they're gone into power, they've gone into roads, they've gone into a few other big things. And we are arguing now that healthcare needs to be on the list. In fact, we'd love to see focused healthcare infrastructure funds that are just there, taking the risk and being catalytic for healthcare. So I think that's something we feel. We've thought through it. How do you do it? What's this kind of structure of it? What should you do? Whether construction, renovation, equipping, what are the partnerships it should bring to the table? How do you select the borrower? And these are some of the things that we have to play back, because if we want this money, we need to be ready for this money. We need to get ourselves in order to be able to attract this money and the money to be able to come to us. But what are the other things that it would need? It would need what we'll call credit enhancements, which has to come from government. Because if government gives the enhancement, then the interest rates can become easier to swallow. Because today, if they come to you now and they want to give you money at 20% or 25%, it's still very difficult. But if there's an enhancement and that comes down to 16%, 15%, it's a game changer. That is catalytic. Similarly, the tenor, it has to be patient. It has to be minimum of 10 years. So imagine that you can access 10-year money at 15%. What we will do collectively as a sector will be catalytic. I can assure you, I've lived this story. So I can tell you that if that money is done at the right price, with the right tenor, and is in Naira, without FX risk, it's a game changer. So what would we do? We would increase access to qualities. We would create jobs. From Iwosan, I like to say I'm 001 of Iwosan because I'm co-founder and I'm the only one who from the founding team who was executive, which was in 2019. Today, we are 850 people as a group. By the end of the year, we'll be 1,000 people. And this is all in the healthcare space. So it needs to be done. Next slide, please. And then I'll just quickly end on two notes, which is the BHCPF. I don't believe we need to reinvent the wheel. We need to work with some of the structures that exist. The government has gone through a lot of ends to create the basic healthcare provident fund, and which is really the channel through which, again, the money from the consolidated revenue fund of the nation is being put, 1%. But is 1% enough? It's not. Can we make it 2%? Can we advocate for that? NESG, can we advocate for this? For more money coming through the BHCPF window? Can we advocate for tax? There's a huge tax reform going through now. The tax laws have been signed, implementation January 1st, 2026. We know that the tax net is going to easily double. How much of that can we bring through into healthcare? And particularly on demand side. Because the demand side, that health insurance that we all say, oh, is really, we've got to support it too. It's got to go from this 19 million people to 60, 70 million people. We have no choice. Because that is what will make the catalytic funding on the infrastructure side. That's what's going to make the business case. Because nobody is going to give us money to build if the people cannot pay. So we've got to do both. And then the last thing, my last slide, before I sit, is private partnerships. How do we really make this happen in a real way? There's been a lot of PPP discussions over the years. Some of them tend to be government building something somewhere that, you know, where it's even built, you can't even get there, but they build it anyway. They call somebody from the private sector, okay, come and run it. But already it's dead on arrival. It becomes your proverbial white elephant. And then there's been more, like what Pathcare have done and others have done by going into public hospitals and saying, give us this and we'll operate it for you. And that has been a bit more successful for sure, but that has not been without its challenges as well. Can we get to the point, which is where we are at now, of jointly envisioning the projects? We work together from day one to say this is what the project needs to be. We identify the location, we do the market study, we say these are the services it needs to render, we say this is the business model, the financial model, this is what it's going to cost, and we go out and raise money. And government says this is what I can do, private sector says what we can do, and we do it properly. And we go to talk to the banks, the pension funds, the big guys. And that's essentially what we've been doing, working on the Lagos Medipark project. It's taken us time. It's been almost 5 years since government started the process. But we're in a good place now where we've been able to envision a project together of multidisciplinary healthcare, of great diagnostics, of contribution to teaching and training. And now that project is now seen as a bankable project, which is now allowing investors to come to the table in a real way. But this is only one. We've got to say, can we use this model and take it on the road and again catalyze our sector by doing this? Now, this is, I know I'm talking about a big project at that end. We can do it even at the other end of care as well. Primary care, you know, the different levels of care can still use the same thinking and the same model. So I think now I have to stop. But just to say, at least I'm hoping that I've left you a few things to think about. And for NESG, should we go and start writing the paper? I'm ready, so that we take it to summit. And we now see how are we going to take this now from just the conversation in this room to action. Thank you very much.
Thank you. Thank you so much, Mrs. Laurier. Thank you. Always good to talk from the lived experience. All right. So thanks for being here. Like I said earlier, for those online, I hope you also getting some of the excitement we're getting in the room. Remember, we're here to talk about catalytic capital for healthcare, bridging the Nigerian systemic gaps in that industry. Just to let you know, we've been addressing some of the issues raised and some of the points made. We're going to go into our panel session soon, but I'd like to just, make these two comments about some of the suggestions that already came forth, because one of the challenges we have in industry also is the dissemination of information. It's a large market, of course, so sometimes things are happening and we don't even know. So on the demand side of things, at the NESG Health Policy Commission, we are thinking that there is an inefficient management of our current healthcare budget. A situation where we have less than 5-6% of the total annual budget going into health, but out of that money that is allocated, 70% goes into payment of salaries, in public healthcare institutions, and then less than 25% goes into infrastructural development. Is inefficient. So if you deploy that same money to getting insurance, like we've been hearing, for certain population catchments or certain population segments, you would deliberately create demand. You deliberately create demand and allow private sector to run these teaching hospitals, the FMCs and the likes, and then just purchase the services, pay for outcomes rather than spend money paying salaries. I think if we do that, our outcomes will be better. So that paper is being finalized. It's going to be published in the course of the year. We're also writing another paper on structuring PPPs to be more efficient. Because today, you don't want to hear some stories from people who have gone into PPPs and got their fingers burnt. So we're also writing a paper on that. Then at an individual level, on the 31st of May this year, in Abuja, we launched the Impact Healthcare Group. Again, this is a group we want to, because we keep talking about the fragmentation. The point is, like Dr. Ajayi said, we can't keep coming to speak the same things year in, year out and do nothing. So we're taking the bull by the horn, as he said. We're trying to bridge fragmentation. We're trying to solve for transitioning of these healthcare businesses as well over time. So you can go online, check www.impacthealthcaregroup.com. Presently, we have 30 healthcare businesses that have come together on a journey to consolidation. Today, you have Nigerian banks in the UK, US, and all the places in Africa because of consolidation. before Soludo's time as CBN governor that forced some of this consolidation in the banking industry, the banks were also that fragmented and were collapsing, any day they like to collapse. All right. So we are solving for that, and the Impact Healthcare Group has been established. It's up and running. We are solving for fragmentation, like I said. Now we are leveraging on the economic benefits of, coming together as a group. And then eventually we're going to be having to consolidate into a single entity. We have a roadmap. And in that roadmap, in about 5 years or less, we will achieve our objectives. So we want to see many more of those formidable groups come up, because that's some way we can also create opportunities to be able to attract the funding that we are talking about. Sometimes we're not able to attract funding because our businesses are too small. I remember going to the IFC in 2010, and they said to me, sorry, your book balance is too small, as EcoScan Services Limited back then. But luckily by 2013, we started, a conversation, and today they are partners in our business because we had to listen to them and do it differently. We have to do it differently. And I believe that by the time we close the conversation today, even as private sector healthcare operators and entrepreneurs, we begin to look at how to do things differently. I may also say, because it will be unfair if I don't mention some of the people who are in the room. I have here, for instance, the team from the Nigerian Capital Development Fund, who are already working with us in Impact Healthcare Group to raise a $50 million healthcare fund, because they see the sense in the consolidation pathway that we are, working on. So we're all welcome. Thank you for being here. We're going to go into the panel session. And in the panel session, of course, we're going to have opportunity for question and answers afterwards. So please permit me to, at this point, introduce our panelists. We have most of our panelists on ground, but we also have one of our panelists online. Today we have on the panel Mr. Abubakar Suleiman, who is the Chief Executive Officer. Can we project this technical group? Yes, the Chief Executive Officer of Sterling Bank Limited, PLC now, sorry. Mr. Suleiman initiated also the concept of alternative banking, non-interest banking within the commercial banking space. And that is doing well, to a large extent because he looked at the demographics. There are certain parts of the country that will not accept commercial banking credits because of interest elements and the likes. So there's an alternative banking pathway that he created. Today, he's not able to join us in person, so I'm not going to bother you with reading all the citation. Of course, he has gone to plenty schools and done great things in the industry. But we have with us today Mr. Olufemi Olaleye, the Group Head, Health Financing at the Sterling Bank Limited. You're welcome, sir. Please, you may take a seat. In the room also, we have with us Mrs. Odunayo Sonia, currently serving as the the Executive Director, rather, of the MTN Nigeria Foundation. Mrs. Odunayo Sonia, her work experience spans education, financial services, telecom, and then, of course, the developmental space. As Executive Director of MTN Nigeria Foundation, she drives the alignment between strategy, the SDGs, and national priorities through various social development programs. She holds an MBA in leadership and sustainability from University of Cumbria in the United Kingdom. Prior to her current role, she served as General Manager, Planning and Customer Management at MTN Nigeria. Mr. Dunayo, you're welcome. Also with us in the room is our own dear brother, an industry veteran who has been in the private healthcare space for over 30 years in Nigeria, Dr. Austin Adebola Okogun. An occupational health physician, CEO of the Lilly Hospitals Group, a leading hospital network in Nigeria with multiple ISO and COSASA's accreditation. Dr. Okogun is passionate about health systems and transformation. He leads MOFMED Medical Solutions Limited as well and serves on several non-profit and professional boards. Dr. Okogun holds an MSc in Occupational Medicine from University of Manchester in the United Kingdom and a Bachelor of Medicine and Surgery from University of Ibadan, Nigeria. Dr. Okogun has also received multiple awards of excellence in healthcare leadership. Thank you, Dr. Austin, for making time to come all the way from Warri, where they are headquartered, to be with us today in person. You're welcome. We have online one of our panelists, Mrs. Olufunke Falade, who is currently serving as the healthcare consultant at the Nigeria Sovereign Investment Authority, NSIA. Previously, she served as portfolio manager in that same organization. As a seasoned professional with extensive experience in healthcare financial management, investment strategy, and organizational leadership, Mrs. Falade has served excellently in her role both in and outside Nigeria over the years. At the NSIA, she contributes to the organization's mandate of managing Nigeria's sovereign wealth to drive economic growth, infrastructural development, and wealth preservation. She is an alumni of University of Lagos, where she obtained bachelor's degree in pharmacy, and her master's is in global health policy and management from Hela School of Special Policy and Management at Brandeis University. Yeah. So thank you, panelists, for being with us this afternoon in person and also online. Let's recognize the presence of the special advisor to the governor who just came in, Dr. Ogunyemi. You're welcome. It will also be unfair if I don't recognize a healthcare enthusiast, a healthcare investor, passionate about healthcare investment, who came all the way from Kano to be with us here today. We have in the house, he's not a doctor, but he invests passionately into healthcare, Mr. Suleiman Yakase. One of the advocates also championing the cause of the Impact Healthcare Group. You're welcome, sir. All right, so we're going to go into it. I'll take my seat so that we can run through the conversation. and then take questions from the audience. For those online, if you have questions, please put it on the chat, and then we'll take it from there. Thank you. Thank you, Zeno. All right, thank you, panelists, for being here. I'm sure you're ready for me. All right. Can we confirm that Mrs. Faladay can hear us and she's still connected? Can we confirm?
Yes, very clearly. Good afternoon, everybody.
Thank you. That's very comforting. Thank you. All right. I like to start from the practitioner point of view. And I like the way Austin is looking at me. All right. Now, because we are here to talk about, catalytic capital, for healthcare investment in Nigeria, bridging the gaps. So I want to know, as a CEO of a thriving healthcare group, hospital group, you have successfully navigated, several rounds of fundraising, to grow your business in Nigeria. Now, what has been your lived experience in assessing finance in the industry? We would like to know from your experience, what are the hurdles? What do you think we need to do differently to unlock access to capital?
Yeah, thank you very much. I think it's important for me to share some of my experience in raising capital.
Yeah.
Luckily, over the past 27 years we've been in business, we've done some rounds of investment that amounts to about $11.8 million in investment in our business, apart from other local funds that we've had to use to finance our business. But what I would say is fundamental is your mindset towards financing itself.
Maybe the mic. Okay.
Is the mindset towards fundraising or financing, because unless you look for it, you may not find it.
Okay.
And unless you think you need it, you may never look for it. So the first question is that, do you really need the money?
Yeah.
And what do you need it for? I also think that even the practitioner needs to have a compelling growth vision that drives the needs for financing. So we took Lily in 1998, and it was a small clinic, 10 beds, 20 staff. Growth was in our mind. We wanted to grow. Because we had Lily, three of us asked ourselves at that time, what do we want to do with this opportunity? We said, and that has remained the driving sentence for what we do. I wanted to grow a business that will live our time. And so we started for it. And you have to understand growth, you have to understand business, understand money. We're doctors, and being a doctor was not enough, to find money or to use the money to grow your business. There was something lacking, which was business knowledge. We didn't understand business, but we knew how to treat patients and get them well. But that was not business. That was medical service. So the first course that I attended, well, were three of us, so at the point I had to be the one who sat on the seats to drive the business, while the rest of my team were doctors and training to become specialists. The first course I attended was how to run a hospital as a business. That was an eye-opener, 2004. So the eye-opener was that I needed more knowledge about business. So we started taking all kinds of courses. But at the point in time, you ask yourself, of course, you are bootstrapping to grow. And you ask yourself, how long will you do this? So we started asking questions. We realized that many of the big hospitals that we admired, that we saw abroad, were actually funded businesses. We're not going to do it from out of pocket, funding. But again, how do you get money? So we started trying to understand how to get money. And we had to do some research. I knew that there were private equity funders and all kinds of other alternative sources of funding. And what the money from banks was very expensive. It has always been expensive. And not many banks want to borrow to us because we're thought to be risky, high risk. Interest rate was high, tenure was short. We didn't have any kind of collateral to put down. So I came across, of course, the building blocks for a good business were putting in place, automation, quality, certifications, training our staff to understand, the business that we're in, governance, to put proper corporate governance in place. All those things that give comfort to investors we're putting in place while we're looking for that investor. The first that I saw online was Abrash at that time, and I saw that they were investing across Sub-Saharan Africa. So I put a note across to them, a long note, and I shared our numbers, were good numbers for small where EBITDA margin was good and all that. And I shared our story and everything. I didn't get any reply. But somewhere along the line, to cut the long story short, I had this advisor that I had from South Africa, who came visiting. And on his way back to South Africa, I saw him off to Lagos. And while we were waiting for his flight, so, that there was this company he worked for some time ago in Ivory Coast that I wanted to visit them. So he checked online and saw that they had an office in Ikoyi here. So we came together and it was Abrash office. And then after all the greetings, he introduced me. And then I told him immediately that I have written you guys a letter. People didn't reply me. They said, who are you? I said, Dr. Steve from Lily Hospital. So, we thought it was 419. that the story was too good to be true.
Oh my goodness.
I didn't want to respond to it. So then Dion, the guy says, of course, Dion, says,
yes,
I know these guys. I'm working with them and you can talk with them. That was how the journey started in 2011, 2012. They then visited our place. Took 2.5 years of due diligence before we got our first money in 2015. That was $5 million USD.
Yeah.
And that was what changed the entire journey and the story. They gave us the credibility that we needed.
Yes.
At that time. And after they invested, we started getting all kinds of other opportunities from investors. And to cut this story short, even as far as getting money from GE Capital to finance our MRI acquisition,
yes,
for such that we only paid 15% deposits for a $1 million kind of equipment.
Yes.
They gave us corporate guarantee and we got it and we paid back over 5 years at 15% interest rate, lower than the borrowing rate at that time. So all these were kind of things that happened. But
great.
What I'll say is the mindset.
Yes.
The never say never mindset that is possible.
Yes.
Knowing what you need to know and to do to get that money.
Yes.
Not just knowing it, but doing it. Believing in yourself and knowing that it is possible.
Yes.
Knowing that every big thing started small and that you can also grow big if you want to grow big.
Thank you. Thank you. Thank you. Thank you. I like the narrative. You see, we've come a long way with Dr. Austin and the team. We share commonalities in that sort of story. So around the same 2010, like I mentioned earlier, we went to the IFC, and the IFC here in Lagos said, well, sorry, your book balance is too small. We don't invest into projects that are less than $20 million. And I was looking for $3 million. So they introduced me to some PE firms operating on the island back then. And those ones too didn't mind me. So we closed the matter. But again, 2012, myself and Austin went to Johannesburg. This was 30th of October, 2012. And by 31st of October, we had a very good meeting with GE Healthcare, when Farid had just taken over as the CEO of healthcare in Africa. And long story short, by February the next year, not only did GE come to the table, GE then came with IFC South Africa to say that thing we discussed last year, we want to implement. So when you hear never say die, that's the never say die. They won't believe in you today or believe on what you're doing, but keep pushing, okay? Because someday they will come look for you. I think that's the story here. And long story short, remember we started 2010. By 2017, 2019. Sorry, I'm mixing up the date. 2017, 29th of November, to be specific, we signed a $25 million investment for EchoScan with the same IFC, Man Capital, and IDH, making that corporate investment into the business. Remember, 2010, they wouldn't even give $3 million. But by 2017, we closed that transaction. So you keep doing the right things. But within the period, we had to transition. We had to do a lot of transitioning. When we started approaching these people, our accountants, auditors were some backyard guys we used to pay. We used to pay like 80,000 naira. They increased it to 100,000 and then to 120 to do our books year on year, right? Of course, nobody will look at it. But before the ISA could make the first investment in 2015, by 2014, we had to onboard Deloitte. So from 120,000 naira accounting to 10 million naira accounting per year, you have to be ready for funding. So you want to unlock catalytic capital as an entrepreneur, you have to, so we tell ourselves the truth, right? That's why we're here. So thank you, Dr. Austin, for giving us that lived experience. I was just adding my own story too. I see the commonalities. All right. We have with us Mr. Odunayo. So I'd like to know now from the developmental space. You're not a bank, of course, you're just a foundation of a notable organization in Nigeria. So as the executive director of this not-for-profit organization, most industry players are aware of the things you do. One time I remember MTN Foundation renovating primary healthcare centers in Kaduna State and re-equipping them and all of that. So you do a lot of all this in the public sector. But we need to know, has MTN Foundation supported private sector healthcare businesses to thrive in Nigeria? Because the NESG, we are about private sector.
Thank you very much.
Thank you.
It's been interesting, listening to the entire conversations. It's always interesting, and I particularly liked, I wanted to say Dr. Lawie, but
yes, she is.
By association.
She is.
No, by association. And Dr.
Yes.
Richard, the story and what you shared, that it's always doable. Well, I don't know who said it. Was it Steve Jobs that it's never been, it said it's impossible until it's done.
Yeah.
And then you tick it and then it's history and more people can build on that. So MTN Foundation is MTN's corporate social investment vehicle. And we're 20 years old. We'll soon be 21 in this year. And yes, we've done a lot around healthcare, and we continue to do. Well, I would say that all our partnerships, funny enough, has been with government, with public. So we'll partner with state governments, we will partner with the federal government and institutes of research. We also have a partnership with NIMA. And it's not because we have a mandate not to partner with private. There's no mandate as such. However, setting up the foundation, it was clear what MTN wanted to achieve. And so there's something we say in MTN, I call it our own statement of faith. And what it says is that we believe that everyone deserves the benefits of a modern connected life. Now, the connectivity is really not about voice and data, but it's about the fact that we understand our role and the power we have to enable people bridge the gaps between them, who they are now, and who they want to be in the future, whether they are individuals or they're, geographical collective, a community and all of that. And so a lot was, our focus really was about the people. Should I put it in parenthesis to say the forgotten people, so to speak, in the communities. And that's why you'll hardly find us doing anything in cities, in the urban areas. We love the rural areas. And so that's how we've operated. But yes, we've done a lot and not just the primary healthcare centers. I think we've intervened in about 230 primary healthcare centers, and we will continue to do that. And the scope of the interventions, keep growing by the day. The last one, we went from just equipping and fixing, the buildings and all of that into provision of water. We tried to do 52, and of the 52 primary healthcare centers, only one had water. I'm not a doctor, but you possibly can have good healthcare when there's no water. And so we then had to now install 51 solar-powered boreholes, gave alternative power, train, and all of that. And we partnered with Pishan to do that, but fully funded by the foundation. We've equipped hospitals, federal medical centers, and all of that. At some point, we set up dialysis and mammography centers in general hospitals. But I'm just saying all of this to show you the breadth of what has been done, and to also say that maybe we haven't seen that private, and we may not have, 500 billion that I keep wanting to call her Dr. Lawi. I don't know why. Put on the, so let me just continue to use that. Put on the screen, because we're, fully funded by MTN. But when there's the opportunity, why not? If there is the opportunity to be a part of, and we love partnerships, we know that we can't possibly do it alone. You understand? And our vision at the foundation is actually that is strange, but our vision is we envision a Nigeria where no one is left behind. But we know that we can't do it alone. And so partnerships, we're very much open. And the one thing about partnerships, and Dr. Lawi said, now I'm comfortable calling you that, Dr. Lawi put it on her slide, is how do you co-create? How are you partners in envisioning? How do you clarify your roles and ensure and know what's your theory of change and what are your outcomes, whether the intended and even the unintended outcomes at the end of it. So yeah, we are open to partners.
Thank you. I don't want to summarize by saying that MTN Foundation, they don't like private sector. I don't want to I don't want to summarize like that, because I want to see that change after now.
Yeah, when there's a business case, so Dr. Benson,
I didn't need your absoluteness.
There's a business case, a compelling business case.
So let me give you a compelling business case. So today, of course, even that statistics came up in the conversation here, private sector offering more than 60% of healthcare to Nigerians. And those private sector players are also in those communities that you are upgrading their PSCs and the likes. Okay? Now, the truth is, if you're deliberate in integrating the private sector into the things you do, you will find it. Okay? We have states today that do cover the under fives, maternal health in some form of, free medical service. But at the end of the day, that free medical service is only available in public sector hospitals and facilities. Why is it so? And sometimes a woman or the family will have to travel kilometers, to go and access a public service facility, whereas there is a private operator nearby that individual could have patronized. So you're buying outcome. So if you're deliberate in buying outcome, I think you can, this notion that private healthcare providers are just there to make profit and rip people off is not correct. Dr. Austin runs chains of hospitals, and the spread is both in the urban and suburban areas. If Dr. Austin knows that you're going to give him, you're going to do screening, mammogram screening, for instance, for 1,000 women in this calendar year, he will give you 50%. You give 70% discount.
So let me tell you something. You said something. You said you can't find something when you're not looking for it. So both sides have to be looking. So
All right.
it's easy for you to flog me here, but the private sector too has to be looking for it.
All right, thank you.
You know, do you see? And yes. So for me, I'm waiting for. So I look back in doing the last 52 primary healthcare centers
yes,
that we did. MTN spent over 3 billion.
Oh my God.
It's not your million.
Oh my, that's my money.
But
that's my money.
But do you see? And I'm looking at it. I wish there was a private sector partner.
Yes.
That we could do all of this and hand over.
Yes, for continuity.
Yes, I personally believe that, you know, free is not sustainable.
Yes.
It's never sustainable. It's going to fail. So having done the heavy lifting, somebody comes and says, you know what, we hand this over to you. You've done the heavy lifting. Yes, we don't want the profit because we're not for profit. But even the face of philanthropy has changed.
Yeah.
We must, it's about what is sustainability? Somebody must be able to make a payment.
Yes.
And subsidized, you know, it is. So back to what you were saying. Both sides have to be.
Don't worry.
Look,
they are hearing us. One of the primary healthcare operators, major one, EHA is in the house.
To allow me to share something.
Please do.
People believe that the private healthcare providers will rip them off. We've done a lot. So we're heavy on monitoring and evaluation. And like I said, we go to the, you know, where people won't go to. Even with
because you're everywhere, you're MTN for.
No, but except because the masks are there. You know, my knowledge of Nigeria has gone, you know, up there because of the job I do. Because people don't want to go to Gombe. People don't want to go to those places, but I have to be there. It's a very strong belief that, you know what, private healthcare providers are expensive. Now, I'm putting it on the table because every other person here, most people here are medical, you know, they're in the value chain. You need to figure out a way to change
that narrative.
And then number two, people believe that private healthcare providers will mess you up.
Cut corners.
And, you know, they just want I was trying to that's what they believe. And, you know, I'm saying it here so that if we're saying all of this investment, the catalytic capital, risk tolerant capital is going to come, we need to address these things.
Yeah.
And so they believe that, you know, I'd rather go to the general hospital. My dad passed a few years ago, but you can't take him to a private hospital. He probably will hasten he will exit, he will check out by himself. So, and I've seen it on ground. When you ask people about, they tell you that, no, they don't want people to misdiagnose. They don't want people. And unfortunately, it's because, you know, it's this thing about a few incompetent stories.
Yes.
Marrying that. So those are the things, because you need these people when the supply side is there. It's going to be a waste if there's no demand.
Demand, yes.
You know, uptake, because it's not free money.
No.
Yes. So I just thought to put those on the table.
Well, thank you. Thank you. Like I said earlier, there's some housekeeping on our part as practitioners and healthcare entrepreneurs also to do. Those housekeeping will continue to do our best. If we can improve on quality costs money. But if you don't also have the guaranteed demand, then it becomes a challenge. Okay, but private sector is not there to rip you off. You are all right. Thank you. Thank you. Thank you. I just need. Thank you. I should take feedback kindly. Thank you. All right. Okay. So I want to speak to, before I come to the banker in the room, because I come from a stakeholder background that will ask you for single-digit interest rate. So I'm not coming to you yet. All right? Yeah. Let's go to Funke. Mrs. Falade, are you still there?
Yes, I'm still there, and I'm a bit afraid of your tough question, but please go ahead. Because you're just throwing them out there.
She knows I'm going to bully her. Yeah. Because you see, at the most basic level, sovereign wealth funds, they are state-owned investment vehicles, okay? That manage countries' financial assets, all right? They do it for profit anyhow, just to build, some sustainability and stability in industries. It can be healthcare, it can be anywhere, okay? Those are the people that you should actually go to for catalytic investment, all right? Now, but what we are seeing, is a bit different in Nigeria. So let me ask, what specifically is the NSIA doing to catalyze the healthcare financing space across North and South Nigeria? Maybe I should take the follow-up questions so you can take them at once because they are interwoven.
Okay.
Now, NSIA has established its own healthcare company. Am I right, Funke?
Absolutely.
Absolutely. And I find it very interesting and intriguing as well, because here you are supposed to catalyze our space. You're supposed to enable investment in the industry. But you go ahead to set up your own company and compete with us.
Okay.
So I'm wondering, what have you done? You don't like us as well?
Okay.
Please go ahead.
Thank you very much, Dr. Benson. And I'm going to take your questions in good faith because I know that you're thinking about healthcare access, quality, healthcare infrastructure as a whole. So thank you for providing a brief of what generally sovereign wealth funds are set up to do. However, I think that usually there are country to country differences and nuances in terms of how those sovereign wealth funds are set up. And I think that for me to do justice to your question, I have to talk a bit about the NSIA in general, its objectives, and how it intervenes in different sectors of the economy. So we're set up by an act of parliament, and we have three main objectives. One is to ensure that we preserve wealth for future generations. The other is to deepen investment in infrastructure, domestic infrastructure. And the third is to provide stability in times of economic stress. So for each of these objectives, we have different ring-fenced funds that we use to actually achieve those objectives. So for the stabilization fund, which is what we use for stabilization in times of economic stress, for example, that's really looking at low yield fixed income securities, because you're not looking at high risk, you're looking at short term, very liquid types of investments. For the objective relating to Nigeria's infrastructure, we have a fund called the Nigerian Infrastructure Fund, which must be invested in only domestic infrastructure assets. And for the last one, we have the Future Generations Fund, which is typically a fund of funds. You can do mutual funds, you can do all sorts of equities. The Nigeria Infrastructure Fund is the only fund that has the mandate to invest in domestic markets. The other funds, you can, do emerging markets, you can do developed markets, and just, play around with those. So for the Nigeria Infrastructure Fund, you are right. We have set up the way we have intervened in healthcare financing, and really just the supply side, because we do have a conviction that the demand side should be seen to by government in terms of the executive arm of government as opposed to a government investment company. So we've intervened by setting up a healthcare investment company called NHDIC. It's the NSI Healthcare Investment Development Company. It's a holding company for any healthcare investments that we have, and we've set up what we call MedServ for short, and in full stands for the NSIA Advanced Medical Services Limited. Also, before I delve a bit deeper into your second question, Dr. Benson, I also want to make the point that through the Future Generation Funds, we are a limited partner in about 12 private equity or VC funds in Nigeria. And through that means we're invested in different types of healthcare services. We're invested in a hospital, we're invested in a medical consumables company, we're invested in a pharmaceutical manufacturing company which provides, which produces oral medicines for Nigeria and broadly West Africa. So we're kind of diversified within the Future Generations Fund. Now, back to the NIF, I think that for healthcare, particularly in the NIF, and we do have a number of focus areas aside from healthcare. Across those focus areas, we invest in 3 different ways. We invest either by creating institutions, such as we did with MedServ. We also co-develop and enter into joint ventures with other willing participants and investors. And then the last thing is we do third-party financing, where we invest directly into a company that is already operating and perhaps is looking for growth capital or something or the other. So for example, NSIA could decide to invest in XYZ company that is already doing 1, 2, 3 and is looking to do 4, 5, 6. In healthcare specifically, we realize that honestly, we can't be everything. And we can't do everything. We can't do it everywhere. And we can't do it all at once. So once we determined that healthcare was a focus area for us, we split that into, we came up with a strategy and we split that also into 3 focus areas. One was looking at tertiary specialties, especially the ones that we see that there is actually no supply whatsoever, or very limited supply within the country. The second was looking at diagnostic services. We also share, the concern that Mrs. Laoye, Dr. Ajayi, and yourself have espoused about, being able to even understand the wave of NCDs, that are coming into the country. And the third was looking at medical manufacturing, which is, tied very closely to industrialization and looking at attacking the root cause of all these issues we're having with foreign exchange volatility. Now, are we competing with the private healthcare sector in terms of setting up MedServ and creating our own institutions? I think not. I think that one of the main reasons why we even have a conversation and we divvy up the healthcare market into private healthcare markets and public healthcare markets is because there's a huge gap in the demand side, right? And how monies are, available to people who are accessing those services. Because in a place where government, whether through insurance or through some other tax finance mechanism, is providing some kind of cover for healthcare services. Healthcare services are typically agnostic of public or private supply. And, people would go to the places that will actually provide those services to the quality that they require them. And so in NSIA, we don't divvy it up like that. We see it as a whole market. And we try as much as possible in terms of investing, because we do not want to crowd out private sector investment. We understand there's a role for commercial banks. I see my co-panelist Sterling Bank on the panel. We know that there's a role for private equity funds, for VC funds. We don't want to crowd that out. So we chose a very niche area where we said, okay, for everything we're going to do, we're going to have a first mover advantage. We are basically going to go into a place where we do not see much private sector investment, prove the case private sector investment could thrive in those areas and then scale. So for example, MedServ started with the NSIA Youth Cancer Center. When NSIA started and deployed 3 linear accelerators in the Youth Cancer Center, we were the first center in West Africa to have 3 linear accelerators. We were the first in Nigeria to have uninterrupted operations. I mean, we're aware that there were linear accelerators in certain public healthcare facilities prior to that, but we were the first to have, to just have there's no story of the linear accelerator has broken down today. And since we opened in 2019, we've not shut our doors once. We also set up 2 diagnostic centers in Kano and Abia states. In those states, although we do all the routine pathology and everything, we were the first in Kano to bring in an MRI. We are the first in Abia State to bring in an MRI as well. So whether it is in terms of the services we're providing or in terms of the markets that we're providing it in, we go to a place where we do not see private sector activity because we really do not want to compete with private sector. As we're scaling our diagnostic and oncology services, we're going to places that typically, like Mrs. Odunayo has said, places that private sector, will not want to go. So for example, we're building a diagnostic center with an MRI and a CT scan in Yobe State. We're building another one in Bauchi. We're building another one in Sokoto. So we're kind of using our ability, our low, well, I won't say low, but lower return on investment to be able to go to those frontier states and actually give them high quality advanced services as well. And I hope that kind of answers your question. So we see ourselves as collaborators.
All right, Funke. All right, Funke. Hold on. They are clapping for you, but wait. Thank you for the work you're doing and all the supply side interventions you're making. At least the important thing is for care to get to Nigerians everywhere they live. So thank you so much. But may I ask you a favor now?
Yes.
And take this back to management because we are looking at catalytic investment in healthcare. All right? So I'll give you an example of what the Afrexim Bank has done with the African Medical Center of Excellence. All right? In that project, which is just supposed to cater for oncology, hematology, and cardiology, we were able to talk them into setting up a high-energy cyclotron. So they have an EBA cyclotron there that will now be producing radioisotopes for Nigeria and West Africa. All right? Ordinarily, that's it. That's about $10 million investment.
Yeah.
But they did it not just because they want to produce the isotopes for themselves, but to unlock the ability for private sector to now get their PET CT scanners and buy those radioisotopes from them instead of, because that has been the rate limiting step. FDG, which is the main radioisotope we use in PET imaging, is very low by 110 minutes half-life. So you can't fly it from South Africa. You can't fly it from Europe. You can't fly it from anywhere close. So they have set that up. And I was talking they opened on the 5th of June. I was talking with a business manager in radiology over there just this week. And this individual says to me, you know what? A CEO of a major hospital in Abuja is already on his way from China where he went to order his PET CT scan.
Yeah.
Why? Because there's a cyclotron now where he can buy the radioisotopes. So can NSIA look at such investments, models that can unlock the value chain down the line, okay? That will help private sector to assess certain key resources that ordinarily they will not be able to afford. It could be in the consumables industry, medical consumables. It could also be even in equipment manufacturing or assemblage, setting up assembly lines so we don't have to import. What does it take to set up an assembly line for ultrasound machines, for instance? NSIA can do that, and it will help the private sector to access this equipment at cheaper cost, from the same market without importation. So please take that to heart and relate to management. And I will also talk to you. I have 2 teasers that I will share with you after now.
Please share. We're
Thank
very
you.
good.
Thank
and
you.
just as a rider to what you're saying, I mean, I
Yes.
agree with you in terms of what AMC is doing. We're really looking for those kind of opportunities. And in medical manufacturing specifically, when we took a deep dive into the sector, we were like, the only way we can intervene in this sector is to actually provide inputs, raw materials. So APIs or excipients, something that is going to make the life of manufacturers easier and is going to incentivize more manufacturers into the market. But point taken on healthcare service delivery, I'm happy to workshop your proposals when they come in.
Thank you, Funke. Thank you. We may circle back to you. I'm going to just take the banker and maybe one more question, to Dr. Kogun. And then we'll take questions and answers because we're running out of time. But before I do that, I think it's important also to recognize the presence of the Director General of NIMA now, Nigeria Institute of Medical Research, represented by Dr. David Oladele. He's a Deputy Director and Consultant Public Health Physician. You're welcome. You're welcome. You're welcome. Also online, we have the thematic lead, the thematic lead for technology in the Health Policy Commission of the Nigerian Economic Summit Group. It's based in the UK, Dr. Obin Newe. He's online. We also have Dr. Maria Saleh, the team lead for the public sector thematic group, also online. They will be speaking shortly by the time we're rounding up. So thank you. Now, let me go to the banker. In a private chat, anyway, he's already told me a number of things they are doing in the industry. Because again, we don't know, we don't hear, we don't see these things. And it bothers us as players in the industry that even though Sterling Bank is one of the banks that have healthcare as a major area in your business, we're not seeing a lot of traction in funding of the private healthcare institutions in Nigeria. So tell us, what exactly is Sterling Bank doing today, especially from your healthcare portfolio, in investing into private healthcare businesses? Maybe I'm thinking mostly about hospital facilities and the likes. Maybe I should broaden my mind, but please just tell us so we know. And then do you have some measurable impact that you can share with the audience? Because information is power. It's possible that after now, you'll be having some conversations with the audience, some people online, some people in the room. So over to you, Dr. Olufemi, yes.
Thank you very much.
Olale, yeah.
Okay, so Sterling Bank has a hard sector focus, of which health is number one. Over the years, we have funded state insurance schemes like the ones in Ekiti, in Cross River, Oyo State. We have funded digitization efforts in government hospitals and private hospitals. Most of these efforts actually were bankrolled by the bank and via PPP arrangements. Then for where it has to do with, debt funding and financing, we are really, Sterling Bank is actually one of the major players. There are several projects going on right now in hospital spaces that are funded by the bank. The challenge has always been that the inflationary pressures and the uncertainties in the economies have ensure that certain projects have not been completed as at, projected. But still, we've been patient and understanding because we always have the end goal, at heart. We have an approach of where we've divided the healthcare space into verticals. We are looking at the retail pharmacy sector, pharmaceutical sectors,
Sorry,
the hospital.
because of those online. Yeah.
Okay, sorry. So we have an approach where we have divided the healthcare space into verticals. We have the retail pharmacy space. We have the pharmaceutical manufacturing space. We are really big there because one of the visions we have is to ensure that Nigeria can achieve drug security. We want to ensure that with the exit of the major players, the major foreign players, we are able to back a lot of the manufacturers, the local manufacturers, to be able to bridge the gap. Also, where it concerns hospitals, we have I really enjoyed the address of the keynote speaker, Madam Laoye, when she spoke about fragmentation as a major challenge in the healthcare space. So what we've been doing is to identify strategic partners, especially those who are looking at consolidating, buying up hospitals, trying to ensure they are able to increase their capacity to render care to as many people, quality care to as many people as possible. And we provide funding to them. Now, as regards equity investment, the bank has invested in a few players, especially in the medtech space, especially those who are solving for providing transparency, digitization, in hospitals, both public sector and private sector. We, partner with a company called Zipline, who uses drones to deliver drugs, in Kaduna, things like that. So we are not just looking to put money in the healthcare sector. We want to do it strategically. Now, as to access to funding, I always speak to a lot of the customers of the bank and those who we try to get on board in bank and discuss strategic partnership with. There is funding for the healthcare sector. The issue is not the availability of funding. There is funding available. The challenge is actually safe places to put and place that fund. The bank is a for-profit organization. We thank God for MTN Foundation that is not for profit. We are a for-profit organization. So we want to make sure we are able to deliver value to our shareholders, and I'm hoping maybe you have Sterling Bank shares. And if you did, you would want us to ensure we deliver value and that your shares with the bank, appreciated over time. So what we're trying to do is to ensure that we place that capital where we believe that we are going to get some return. But I must say that as a bank, we are not just thinking about profitability. We're also thinking about impact. So our MD and the board and the management of Sterling Bank actually has that as what we consider. A lot of things go into consideration, and profit being one of them is not the only factor we consider. So we are open to discussing. We are looking at I was so happy you mentioned the infrastructure fund. Sterling Bank is actually looking to raise about 200 billion to support expansion in terms of infrastructure, medical infrastructure, especially, although it's broader because we have a hard focus. But medical infrastructure, is something we are looking at to provide cheaper sources of funding, patient capital, for hospital expansion, modernization, getting certain, equipment in, supporting particular sectors like oncology, cancer care, advanced laparoscopic, surgical intervention, things of that sort. Now, I've been a doctor myself. I really want to have that happen. So we identify those players, look at what we can do with them, and we partner with them.
Thank you. Thank you. So again, forgive my fragmented introductions today. I will keep introducing until we close. All right. So in the room, we have the president of the Healthcare Federation of Nigeria, Ndile. Again, one of those honorary doctors. We also have Dr. Pamela Ajayi, who is the immediate past president of the Healthcare Federation of Nigeria. Now, why am I mentioning them? Of course, we have also our new executive secretary of the Healthcare Federation of Nigeria. I think one of the things we need to start to advocate for is the issue around the infrastructure fund, the pension fund. Let that fund, like Mrs. Laue said, be dedicated to healthcare infrastructure. Let's have access. Today, if you go to Abuja and elsewhere, you see lots of estates popping up here and there. They are leveraging this infrastructure fund to a large extent. So if healthcare can be brought into the net to be able to access the pension funds, I think we'll run a lot faster than what we're doing presently. Yes, we can also write from the NASG. And we're already working collaboratively with HFN. Of course, I sit on both sides. All right. So we're going to do that because it's so critical to catalyze the space and unlock that sector. And it will happen. If we advocate for it, it will happen. It's just to show the reason why it is critically important for the growth of our healthcare industry, whether private or public for that matter. Again, we can tie it around PPPs if they want. We can tie it around standalone facilities as the case may be, but it's something we need to advocate for because it's patient capital, long-term financing, as we say, and likely going to come at a better rate than regular commercial rates because we need that. Now, the challenge with this dollar-denominated foreign direct investment is the fact that just FX fluctuation can wipe you out of business, so it's not sustainable. So, Dr. Austin, and I will ask this question, and maybe you, Doc, you will also respond to it, Dr. Lale. What do you think, though you mentioned it partially, and I think I also said some things, but please tell us, because there are people in the room who are at that stage of looking for growth capital. What should one do as a private healthcare sector player to unlock access to finance? I'm talking operational things now. I'm talking about, being very practical, real life, things that we give Dr. Lale some comfort, for instance, as somebody who has gone through that cycle a number of times. Thank you.
Yeah, thank you very much. I think you have to prove that you need the money and you know what to do with the money. So every private organization in healthcare, hospitals, need to have data to prove their performance over time. Like the traction that you need to convince investors that you can put in money and make more money, or you can give them the confidence that you'll be able to pay back. You also have to have a compelling vision, for growth. That means that when you are giving the money, you know what to do with it to generate more value and therefore payback. So one of the problems we have in our industry is that many of the hospitals still rely a lot on paper in their operations. And they themselves don't even know what's going on in the business. So how can you tell somebody else what's going on in the business? And how does the person have visibility that when the money is given to you, that you know just what to do? So I think that is fundamental. And when you know that when you get the money, you have a story on how you use the how you spend the money, and you can back that up with historical performance. And you can also prove that you have also put in your own money, because no investor is going to put money in without saying that you put in your own money to the business. And with all that, you can get money. But I want to add quickly that in my personal observation, I see that many of the problems we have in our industry is such that we neglect those at the base of the pyramids.
Okay.
In terms of the provider networks.
Okay.
Even the money comes to the room now, the money going to get trapped at the top. It's not going to trickle down to the bottom. All this one we're speaking grammar here now, the Catalytic Capital will never catalyze those at the base. It will only catalyze those at the top. I've got several investments where when I look around, I don't see the smaller players. And I keep asking, where are those guys? Now, you mentioned that more than 60% of our patients go to private sector. But in reality, more than 60% of those that go to private sector goes to those small players.
Yes.
So if you really want change, you start from there. So now, those guys there don't have the business knowledge, don't have the structure, the process.
The management processes.
So we need to think ecosystem. I want to build an ecosystem support. We need to go back to the basics. It has to be a bottom-up kind of growth. We have to go down to the basics and say, look, let's create a way to educate, to support, to digitize those smaller hospitals. And naturally, when they have the knowledge and understanding, this thing you're talking about, amalgamation or M&A or whatever, will happen naturally. Because the fear of what the bigger guys will do to you that make nobody want to hear about M&A or sell your business to a bigger structure and all that. So we need to go back to that spot. Because you know why? You hear all the time about startups, the tech startup everywhere. You hear about accelerator programs to help tech startups to grow and understand money and how to grow. Who is doing that for these guys at the bottom of our listing? So yes. So I saw that on LinkedIn. So that's where I think we need to get Zenith Bank and MTN Foundation.
Oh, God bless you. Why are you? You see, I told you that we've come a long way.
Yes. We need that foundation to catalyze that transformation.
Yes.
To bring these guys in. I know that pharmacists have done that before with the legal business, but we need something more basic, virtual, going to them, who is consulting for them. Very early in our own growth phase, we had a consultant. I was telling somebody the other day that since 2001 to date, almost every quarter of every year, I hold retreats to my team members.
Yes, they do. I've attended.
Because a consultant introduced that to me at that time, and I could see the value, and that had been a continuum till last month. We still had one.
Yes.
You get the point? And that is the only way you can share your vision to your people, because your chick cannot make a forest. You cannot be running alone and nobody is following you at the back. You get the point? You need to get, growth doesn't just happen. It doesn't just, it's intentional.
Yeah.
And you have to realize that it relies a lot on the know-how, not just know-how in terms of talents of your people, even the know-how in terms of the problems they're solving.
Yeah.
People don't even know what they're solving. People just come to work for the 8 to 5 and get their money. It has to be bigger than that. It has to be more than that. Get it? How are we getting our people to be part of what we are doing? By having the skin in the game, and ready to put in everything to make you grow and sustainably, not just grow sustainably.
Yeah.
So we need to go back to the basics. When we go back to the basics and get these smaller ones doing the right thing, because the highest risk in our entire healthcare delivery system is at the bottom.
Thank you.
That's where all the harm is taking place. That's where the HMOs are losing money to provider fraud. Everything happening wrong at that bottom because we fail to address the fundamentals. Yeah. Let's go back there, and money will flow in, and then the rich change you want to see will start.
Thank you. So let me add a voice there. Then, Doc, you will tell us, because as a money man, you don't just throw your money around. There must be certain indices. You guys work with checklists. What are the, those critical things? But let me just say, based on the point you made, that bottom of the pyramid, those operating at that level, the primary healthcare centers, the 5 beds and 4 beds and 1 bed hospitals, 20 beds. Okay. If there's a way that the work that maybe an MTN Foundation is doing can co-opt, you go to a region, okay? You go to a region. You are not just focusing on the public sector players in that region, but you pick the private sector players as well. Upscale them in terms of training, capacity building, okay? Then do your renovation of those facilities and equip them. And then thereafter, give them the opportunity to run the services.
I don't want you to talk about equipping them. Let's not spend money on equipping them. They will know what to see.
I even
let me tell you something.
Don't put me on the spot.
Once
I've told you,
once they have knowledge,
let a business case exist.
Yes. When they have knowledge
together and
they'll get it.
whether it works or not.
Oh, no,
there are things we will never do.
Okay.
Do you understand? Because of the way we're set up. But let's see how
just knowledge.
Let's even see how it, a business case, and then you can have 100, 1,000,000 things in the business case. And MTN Foundation says, you know what, no matter how you speak this grammar, the only thing we will do
It
is
is
fun.
And that's
But it's a start of point.
Uh-huh.
And then we know that if we say we're going to do one, we will follow it through. We will measure and we'll
Yes.
see the impact.
Impact. Okay.
Yeah.
Thank you.
Right.
All right. So long as we are doing something that will change the space. No, they will answer.
Okay, the checklist.
Yes.
All right. So, in the spirit of what Dr. Austin, the door Dr. Austin opened, let me start from the lower rung of the ladder. So for small players, there are certain things that they may not have. So, because we know most of them do not have records, they don't have, finance teams and all that. So we provide unsecured funding, though there's a limit of about 20 million for that sector. So what we'll be looking at for that sector is, number one, we want to find out their capacity. What do they have the capacity to borrow? Right. So we ask them for their statements to check their turnover. There's, way we are able to determine analyze what capacity they have. Then we are going to be concerned about them having the licenses to actually operate. So if it's a hospital, there must be a doctor with a valid license, a pharmacy, and a practicing license, environmental license and all that, then we are very particular about, even to an extent, how they run their business. We'll go and do a visitation. We want to make sure that there is an actual business that is running there. All right. And we're not, funding people who are not supposed to be funded. So yeah, then we also want to check for their character. Are they debtors? Are they chronic debtors? Are they people that have bad credit reports? Because sometimes small businesses like that don't realize that even if they have a PSCN bill that they've not paid, a Kenya Electric bill, if a Kenya Electric files it with credit bureau, all of a sudden they have a negative report. And when we see that, we cannot give, loans to them. So we have to check, for all of that. But when we are moving, say, let's say the middle, portion of that ladder, maybe.
Rent.
interest rates.
No. He has not come to that.
Okay, for interest rate for unsecured, for those in lower rung of the ladder, lending to a lower rung of the ladder is very risky, and we price that into that, into the pricing. So the riskier a target market is, the more expensive the rate is, because we have to have a premium that is added to cover for if there's a default, because usually NPLs in those kind of segments is really high. Sometimes you can have it as high as say 10%, 13%. I'm trying to bring my NPL in that bucket down significantly, whereas I have an approval that says that I should not go above 3%. So even across banks, you will see that it's the same, in Onisha, in Kano, in Lagos Island, you will see that spike. So when you go to the middle portion of that,
No, but you have not answered the question on the rate.
Okay, for
20%,
for the rate,
25, 30.
currently we are offering 28% to female-led businesses. All right. So for female-led businesses, we offer 28%. Then for our brothers, male led businesses is a bit higher because they.
Oh, I see.
All right. Let me tell
So
you
for working
guys.
capital, it's 1 year. For asset finance, we do 36 months. Yes.
So let me
Now
tell
we
you
also
guys. Okay, go ahead, finish.
we are also looking at increasing working capital to 2 years, so that you have more room to play and sweat the capital that we've given you. Yes. Then for the players that say are in the middle category, maybe like a hospital that seats 20 beds, has revenue of say above 500 million per annum, 500 million to 1 billion. What we've done is that what will help make access easier. I think one of the major challenges we have in the healthcare space is that a lot of practitioners are okay owning 100% of zero, rather than owning 10% of 10 billion. So Here's the thing. So imagine if you come and you say, okay, I need 5 billion. I want to borrow 5 billion. I want to borrow 1 billion. And I'm asking about the board of directors, and I don't see anybody that is creditworthy there. Or I'm looking at the management team, and I'm looking at your CFO. You don't have a CFO. Alarm bells start ringing. And when you bring your auditor and you say it is Kunle Fashion, I hope there's no Kunle Fashion and Co. All right. But so all of a sudden, the credit rating of that request begins to go below B negative, begins to become a C, and all of a sudden, board has to approve. Whereas if Dr. Austin comes to me with a request,
I'm with the call.
Yeah, I'm with. Whereas he's going to do the request and I do an analysis, he's going to most likely be investment grade. So I would just most likely need management to approve that. You may not have to get to the board. So that is what we'll be looking at, when we're talking about the mid-level. But when we're looking at the players like, Dr. Austin, Madam Fola, then the conversation is a bit different because now we understand that there's a team in place. We understand that they know what they are doing. They have the track record to support. Then all of a sudden it becomes about what can we do? How can we make this work? How can we ensure that whatever project you are trying to get into succeeds? Yeah.
All right. So MTN money is better. All right. So
MTN money is not as much as
grants.
No, so I think at the end of the day, we still need to do something to catalyze the base.
Yes.
Okay.
Very important.
So we may not have all the answers right now, but we will think around it and come back to you. Okay. I know also that one of the things that the banks look for in a certain geography in this country is 1, your age. 2, have you built your house in the village? 3, do you have a second wife? Because if you have those already, then it's likely that truly the money is going to go into the business. But if you don't have a house in the village and you are coming to them for money, they are not going to give you. Because they know that at that age, you're likely going to use their money to go and build your country home or marry a second wife. Are you a red cap chief already? If you're a red cap chief, you're more credible. Again, because you have so there are many metrics that they use. Different banks, different metrics, but all the same, they want to safeguard the investment, all right, because it's an investment. Our sector, yes, is a risky sector because, again, we have not gotten the demand side right. Once we have the demand side economics right, and say 40, 50% of the population can actually access care at the time of need without money in their pocket, the industry will leapfrog. So let me take questions from the audience, contributions. Yes.
Yes. Just a short one. So I know we've talked about, setting up the fund and all of that, but I'm an advocate of what I call the health we have the road infrastructure tax credit scheme. Why don't we have a health one? And I think it's something NESG should. And what it does is that, big organizations in Nigeria commit their taxes, project your tax into the future, but you use it now. And that's why you find a big company, of course, not the MTN Foundation, like MTN, constructing roads.
Yes.
Because that is the funding that is used. So why are we not asking to create a health infrastructure tax credit scheme and let organizations invest? Because when you invest in it, your staff will go to those hospitals, whether you are remodeling hospitals or you're actually, building. That's one. Then the second thing for me that if we can do is that I hear you about the funding and all of that. But for how long are we going to get funding? For how long are we going to create, pools of funds? And all we still do is change it into foreign exchange, open LCs, and bring back in, the impact is already depleted. Even though we'll still gain a lot of traction, but we could do more. So this is a starting point, and we can't do everything at the same time. But I think it's important to begin to think around how can we create local substitutes not for everything,
Yeah.
but we definitely can do for some things. And that will make it easier. You know, it will complement the efforts that people like yourself, Dr. Lauya, and every other person here, Dr. Ajayi, everybody goes through to get, you know, what they need into the country. So I think that we need to do, you know, that.
So that's why I was mentioning to Funke, you know, about what we need to do to unlock that local manufacturing space. There are some things that are easy to achieve, you know, just bring machine components and couple them here, assemble them here. Now, GE, this was as at 2014, 2015, GE was building an assembly plant at Tinapa in Calabar. And as at when we were having that conversation, they had already spent about $250,000. But then Tinapa collapsed. That project really haven't seen the light of the day. It was supposed to be an export-free zone. So they were going to set up the assembly plant there so that from there they can also export to the rest of Africa and the sub-region. So we just need to do things differently, like you said. Choose areas that are just like they've done in pharmaceuticals. Today, it may just be refilling of shells, you know. Every other thing is imported. You just do some local packaging and refilling and branding and all that. We can start by coupling, assemblage, and, you know, it will go a long way in removing that foreign exchange component in importing the finished products, you know, and that can catalyze our space. So those are the kind of things that the banks, long-term project like that the banks can also look at because they are actually profitable. Okay, local manufacturing will always be profitable, especially when you have a sub-regional market. Today, you have the Africa Free Continental Trade Zone. You can sell to the rest of Africa, not just Nigeria. You have the likes of ABC Health that will also help you to open some national doors because they have reach. All right. So let's keep the conversation going. Questions from the, yes, let's pass the mic. 2 questions from the in-house audience. Anybody online? I received, I think this is a question or a comment from online. It says, when we talk on public-private collaboration, as stated earlier, how we truly ensure that catalytic capital investments complement rather than compete with government healthcare spending. So when we talk about, you have a question too. Okay, that's 3. So when we talk about private-public partnerships, today we're even talking more about public-private integration, where private capital can be mobilized to support government infrastructure to scale and to operate more efficiently. I think Ms. Lauya also mentioned that in her presentation. So in that sense, it's not competition, but collaboration. There's already something on ground. You're just enhancing it to become better and to serve the population better. So most of the PPPs are complementary. They are not competitive, you know, one competing against the other, for instance.
Dr.
Most
Benson,
of them. Yes.
Sorry, apologies. If I may, just as a quick answer also to that question. I think you had alluded to it at the beginning of the session when you said we need to think about how we channel financing for the health sector. So I think that if public sector decided to pay for outcomes, decided to pay for lives, as opposed to inputs, we would see that demand side financing will flow from governments. So you're actually not taking over what government is supposed to be doing. And the private sector will go. They will set up the equipment. They will set up the healthcare infrastructure. They will take over the public tertiary hospitals and operate them. Those things will just naturally catalyze, just changing the way we spend will, show exactly what it is that each party should be doing. There'll be no competition and there'll be more for everybody to do, and will really unlock the market.
Thank you, Funke. We are already writing that advocacy paper. That paper from the NESG is going to be published, and we're going to engage the relevant authorities. Some countries like Ghana, Chile, all kind of places, they are already doing it, where you pay for outcomes for certain population subset, okay? And at least guarantee them access to care at a time of need. And that unlocks the space. Because if today, as a diagnostic service provider, I know that I'm going to get 1,000 patients, for, I used mammogram before, and I don't have the cash, but I know these patients are going to come. There's a guaranteed income that is going to come from there. Sterling Bank, I can even negotiate rate with Sterling Bank from 28%. So, I don't. Well, I may just tie scarf, and do transgender after the conversation. Then I will change back. But the truth of it is that if you have guaranteed offtake, you will unlock the supply of services. So that's what we are advocating, and that's what we will continue to push for. Whether it is by the subnational, some states guarantee certain schemes, or at the national level, this is what we are supposed to be doing. If we really want to cover our population, especially the vulnerable population, we need to do that. As we also talk about increasing the basic healthcare provision fund. Yes, our time. All right, let's take, yours is a comment. Okay.
Thank you so very much. I don't know if I could have given anything for this incredible set of panelists that we've heard today. It's so real. The conversations are things that we can use, practically as we go on. I just want to say that for the purpose of the mix, there is a private sector non-health representative on this panel. I hope we heard her. She's not just MTN Foundation, she's representing every other public non-health money. There are a lot of 3 billion nairas seated there. So where I'm saying that is that the health community, the health sector, especially private health sector, we need to pay a bit more attention to the new dynamics. Donor fund is almost, completely gone. This is the new money. Fewer people are going to edge towards the 28% for women. But you see this philanthropy money, let's talk more with them. How much more can we do? What can we do differently? We need to unlearn some things, because what I see is some bit of rigidity around the things we know already. Yes, and how we do it. But if we sit back, she doesn't have all the answers, because she still needs to report to her board to say, this is what I'm hearing from here. But there's so much in this sitting right now that we can all use for the new health plan for the country and for the continent. And so I really want to appeal to us to do much more of engaging this category of persons that are willing, that are already doing, some of them are doing already. And there's also even Sterling Foundation. You see, the Sterling Bank, the Sterling Foundation looking for initiatives that will help catalyze their reputation. There's money there as well, but it's just having the right conversation and being patient enough to listen to their own dynamics and how best to use the money for mutual benefit. Thank you very much.
Thank you. We will unlearn, don't worry. We'll change.
Thank you. Oh, okay. Hi, everyone. My name is Dr. Ifunanya Iludibe, and I work with EHA Clinics. And thank you, Dr. Benson, for the nice segue, because my question, I have two questions. I have the mic right now, so I'll ask two. My first question is for Mrs. Sanger, and then my second question is for Dr. Olale. Very interesting to me is the work that MTN is doing, revitalizing primary healthcare facilities, because we play in the primary healthcare space. And because we're a social impact venture, you know, beyond our for-profit clinics, we always think about how we can make impact in underserved communities. And we started going into these public-private partnerships with the state governments. And sustainability is very important. And a lot of the times when we have these conversations and when we talk to these state governments, they have renovated a primary healthcare center and they have equipped it, but haven't thought about who's going to see the patients in there and how we can actually create sustainable outcomes. Because quality is beyond a building and it's beyond equipment. It is people coming there and getting well sustainably. So I think that buildings are great, but outcomes are better. And it would be important to think about a partnership that creates sustainable, impacts on patient outcomes. Now, understand where you're coming from. People have to pay something. And one of the things that we've been able to do with our community health programs is figure out how to use philanthropy money to make care accessible and affordable for patients. I think that there is a niche, there is a conversation that can be had. Let me use one of the states, for example. One of the things that we realized very quickly is that the state has a health insurance fund. They have a capitation that they pay for patients, but very few patients show up. One of the first things we have to do is actually go into the communities with community health extension workers and get people to sign up to the health insurance. So if we are looking at something sustainable, that 3 billion naira, if we work together,
This 3 billion has cost a lot of money
together. Because a lot of the times we think of equipment. For me, when we think about primary care, we have primary care facilities around the country. Sometimes the biggest equipment we have in this is an ultrasound machine. It doesn't have to be that big. What we need to deliver care to 85% of people is not big equipment. It is things like making sure essential medicines are available, making sure consumables are available, making sure healthcare workers are paid and available, make sure there's electricity powering the facility. So just wanted to think about that.
So just let me, and I know time is gone, but fantastic. We can always take the conversation out of here. However, we don't just do buildings. So you're enrolled on a drug revolving scheme for 1.5 years, each PHC, and you have consumables for 1.5 years. And it doesn't mean that everything is hunky-dory. No, but we do that, and then we will not go to a primary health care set. We also are very careful about the way we spend our money. We won't go to arrive at that 52, we visited 305 communities in Nigeria. So that tells you the granularity. And it's just because, we don't just want to do things because we're doing it. Now, this is the back end of what we do. Nobody sees, all of that. To get into a community, we go see the village head, the women leader, the youth leader. And because except you do that, it's going to be, people tell us at times, at least I've seen 2 communities who told us that, okay, MTN has come now, it's MTN now. Don't worry, very soon, Dangote will come. And maybe another person will even come out after that. So that is also what we have to do. But yes, for me, it's about doing, that 3 billion, I wish it would have an impact. It's not going to be a lifetime impact, but at least extend the shelf life of the impact by 5 years at the most. You understand? But we can take the conversation.
Awesome.
Very quickly add, and because Njide is right here next to me, And we had the experience, both of us, working together in starting what was one of the early community health insurance schemes. Now, it was subsidized, and that's what you're saying. It needs a subsidy because what the people can afford does not normally, they need a top up. And with that subsidy, we ran this program in 2 states for 10 years, and we covered 1 million people between Kwara State and Lagos State. So I think what I'm just trying to say is that there is a lot of learning because it wasn't all, easy. That's one. 2 was the fact that the subsidy came from foreign money. It was the Dutch government. And as we're saying, we need to find ways of replacing with local money, and local philanthropy. But I think the models are there, and there's a lot that we can certainly unpack to really hopefully try and take some of this forward.
Okay, so let me.
Just one moment. Just one thing, and this is just for Sterling Bank. And I was just listening, in terms of how you structure debt financing. Ours is a little unique. We do have the structures, we do have the quality, we just don't have 200 beds. And so we may not be able to get the credit ratings that Annie Watson will get, but we're not at the bottom of the pyramid. So sometimes we find that within the market, there's a gap there. They don't know where to place us, right? We have the structures, we have a CFO, we have a governance structure, we have the accreditations, but we don't have the procedures that are going to, do 2 million naira procedures. Our business is lower margin, but in terms of scale and the ability to scale and serve a larger part of the market, I think that that's something the banks are not seeing. I think it's very myopic looking at, but you have 200, this person has 200 beds. You have altogether, maybe you have 10 beds spread around Nigeria. But if you think about what that potential is in terms of what the startup costs are, the support structures that already exist, that is where you can possibly scale. So I just want you to think a little wider. Thank you.
Yeah, so like I said, like everybody has said, let's not just make it a talk shop and complain about what has not been done. So while I'm going to talk, I'm going to speak for Mrs. Sawyer. I'm a beneficiary of MTN Foundation. Great. And you didn't really say what you really have done. My name is Adeyemi Adewale, Managing Director of Adchem Healthcare. What does Adchem Healthcare do? Well, what we are known for is things around dialysis. Good. But we've done a lot more with MTN Foundation. MTN Foundation has fed my family since 2011. But no, wait, because the first thing that you didn't say is that they don't just give equipment. We set up dialysis centers in the 6 geopolitical zones, and we did it for 10 years. We collected money, subsidized. It was subsidized at 15,000 naira for a long time, even when dialysis had become 35,000 naira, because the money was first collected, subsidized. They provided all the equipment, including boreholes, a television, fridge. We ran the place, we changed the bulbs, borehole, everything. And there was this fund that we had with each of the hospitals. After MTN withdrew, then that money was still there, enough to provide that subsidy for another 3 years. Then when they now said the hospitals could, go away, everybody just took the money that was left in the coffers, and everything went back to them owing us money and all whatnot. So what I'm trying to say, and again, we didn't stop there. Out of the number of centers, primary healthcare centers, we did 150 of them. And what MTN actually has, MTN Foundation has, they have data.
before we even did the renovation, we had to go to 17 states. We did 17 states in the north at once, where we had to they have enough data about what is the condition. We gave them pictures, photographs, so many things. And even with the running the dialysis centers, we had to give monthly reports with graphs, and quarterly we would meet and we will compare and everything. So there's a lot. What I'm trying to say basically is that we don't need to reinvent the wheel. I used to be on the exco of HFN. I think if MTN Foundation works with HFN, we can keep things that we have done in the past, keep them going, and use a lot of what you have so that we move forward. So we don't keep starting all over again. Let's have a conversation. There's a lot that we personally have a lot of data and information. If you don't have it, we will provide it. So I think
thank you. So we'll keep the conversation going. That's the whole idea. In catalyzing the industry and the space, it will not end in this one-day event. So we don't have questions from the online audience. Thank you so much for the participation today. We've already exceeded our time, but before we close, please permit me to call on Dr. Maria Saleh and then Dr. Obinna Newihe to give closing remarks, one after the other. Dr. Maria, you go first. Thank you.
Thank you so much. Hello. Thanks so much, Dr. Benson. Unfortunately, Dr. Maria had to drop off. So this will be a bit of a joint talk on behalf of myself and Dr. Maria. I want to appreciate everyone for taking the time. Apologies, we have stretched longer. That's just testament to the quality of the conversation that we've had over the last almost 3 hours now. At the NESG, under the Health Policy Commission, we have the Health as a Business thematic group, which Dr. Benson very actively leads. And there's also the Public Health group, which Dr. Maria leads, and the Health Technology group, which I'm fortunate enough to lead as well. So we've seen one side of the conversation around health as a business. Myself and Dr. Maria work on 2 different arms, which are synergistic all under work as a Health Policy Commission. One of the most interesting things that we heard today that I took from this meeting is that money is looking for opportunity. It seems strange in a market where people are actively looking for money, but we're getting feedback from people who've released the capital that they're actually also looking for the right kind of opportunity. And I think one of the biggest things that I have taken out from this conversation today is how do we frame the risk? There's talk about, catalytic capital, being patient, being risk tolerant, and being impact driven, but there are concerns about commercial viability and fears about how this capital should be deployed. So I think, as healthcare businesses and practitioners, one of the things we need to think very deeply about that I've taken out of this is how do we tell our story and how do we frame the risk? If the bank does not understand, if we don't put our books in order, we don't present a clear case, then a bank that is even looking to give out capital is not able to adequately frame the risk of investing in various healthcare businesses. Dr. Maria was very keen to say that I mentioned about 100 million plus Nigerians at the moment are vulnerable and don't have access to quality healthcare that is affordable. So those are twin issue, two sides of a coin. The healthcare has to be of very high quality and it needs to be affordable. And one of the things that the healthcare, the public health group has been researching and putting out a lot of thoughts about is on PPPs. And I'm very glad that we talked about PPPs and as to how do we continue to frame them to make them as effective as possible. I'll stop here by saying we mentioned the need to have local capital contribute, and we have seen that with the rise of infrastructure funds, and then pension funds are willing to come into that. In health technology, one of the things that has really affected the space, especially looking at very early startups and digital technology businesses, is that 90% of every dollar, 90 cents of every dollar that comes into an early stage health technology business in Africa is actually money from abroad. And what that means is that investments into health technology businesses is subject to the whims and caprices, as it were, of international investors. And so when the market goes high, we get a lot of interest in our health technology businesses. And when the market is low, as we're seeing after the post-COVID enthusiasm, we're seeing very low investments in health technology. So just as we're also looking at how to mobilize private capital and learning today from the investment in infrastructure funds, there's also need to get pension funds as well to be limited partners into early stage technology funds. At the NESG, at the Health Technology Group, some of the things that we are looking at as well is to map the ecosystem for health technology to help us realize what is actually going on, to support putting out information as to the state of things. And so we're going to be publishing in the coming months a state of the health tech ecosystem and providing a mapping of the health tech ecosystem as well. So thank you so much for the time. Again, we don't take it for granted. It's nearly 3 hours of your time committed to talk about catalytic financing for healthcare in Nigeria. Thank you so much. And I turn it back to Dr. Benson for a fantastic session. Thank you so much. On behalf of myself,
Thank you.
Dr.
Thank you,
Maria.
Dr. Obina. Thank you. All right, join me with a warm applause to my panelists. Thank you for the insight you have brought to the conversation. Thank you so much. And if I have bullied you, forgive me. Thank you. Now, if you have not, if by any means you have not, yeah, please. If by any means you have not signed in your attendance, please do so. Refreshment is still served. You can get something to drink. Then lastly, we're going to have a group photograph right there by your left-hand side. So let's finish with this session. Sorry. All right, thank you. So don't go away. There's group photograph that will take place out there. Over to your right.